moving ahead with the next session, Women Health Symposium, I would like to invite Dr. Rinkal Gohil ma'am and Dr. Heena Goswami ma'am for the chairperson. And I request both the chairperson to introduce our speakers for the session.
Good morning, everyone. I'm Dr. Heena Goswami from Jamnagar. First of all, I want to thank Dr. Yash Patel sir for this opportunity. So today's topic is on women's health, and the first session is given by the speaker, respected speaker, Dr. Subhash Wangnoo, sir, senior consultant endocrinologist, Apollo Center for Obesity, Diabetes and Endocrinology, Indraprasth Apollo Hospital, New Delhi. Sir, today's topic for sir is pre-gestational diabetes and family planning, role of primary care physicians. Over to you, Subhash sir.
Yeah, today I'm going to talk pre-gestational diabetes and family planning, the role of primary care physicians. I'm grateful to the SwasthyaCON for allowing me to talk on this prestigious conference on a topic which is very, very common. You know, pre-gestational diabetes is a condition in which a woman with diabetes before the onset of pregnancy becomes pregnant and therefore vulnerable to increased risk of maternal and fetal adverse outcome. Pre-gestational diabetes has been observed in 1 to 2% of all pregnancies, but the rates are rising. Approximately 1 in 9 women have diabetes, and 35% of people with newly diagnosed diabetes are women of reproductive age. The increasing prevalence of diabetes among women of reproductive age is largely driven by an increase in type 2 diabetes, which in turn is driven by the unhealthy nutrition, obesity, and increasingly sedentary lifestyle. Now, what is the importance of identifying the pre-gestational diabetes? In order to minimizing the feto-maternal risk, the perinatal mortality for women, fetal demise, macrosomia, neonatal hypoglycemia, spontaneous abortion, fetal anomalies, and the maternal preeclampsia and the retinopathy. Congenital malformations secondary to the maternal diabetes can be greatly reduced through optimization of maternal health during the pre-pregnancy period. Multidisciplinary team, obstetrician, gynecologist, maternal fetal medicine specialist, dietitian, diabetes care and education specialist, and endocrinologists and diabetologists will help to minimize all the feto-maternal risk. Special attention has to be given to the comorbid condition. We have to screen for comorbidities and complications like retinopathy, especially in type 1 diabetes, because maybe a new onset retinopathy or worsening of pre-existing retinopathy during pregnancy. Nephropathy, there might be worsening of nephropathy during pregnancy. Dilated eye examination are recommended in the first trimester and may need to be repeated based on the level of retinopathy found. Before pregnancy, all women should be prescribed a prenatal vitamin with at least 400 microgram of folic acid and 150 milligram of the potassium iodide. Folic acid is important to reduce the risk of spina bifida. Now, what are the glycemic goals and recommendation before and during the pregnancy? We have to keep the HbA1c ideally less than 6%, but individualize this HbA1c to avoid the low blood sugars. The fasting plasma glucose has to be kept less than 95, the 1 hour post-meal less than 140, and 2 hours post-meal less than 120, and the time in range should be more than 70% for those who are using continuous glucose monitoring system. BP should be maintained less than 130/85. And apart from this, lifestyle modification, weight management should be given the top priority. During pregnancy, we have to stop ACE inhibitors, ARBs, and statins and we have to shift to the insulin because none of the insulin, they cross placenta. Remember, treatment will be dynamic, often changing throughout the pregnancy and into the postpartum period as a result of the varying effects of pregnancy on the glucose levels. Now, coming to the family planning, pre-conception and the postpartum. The contraceptive ideally allowed are the combined estrogen and progesterone hormonal contraception, which can be in the form of oral pills, transdermal patches, vaginal rings, and injectable medication. Progestin-only pills or the contraception involving only the progestin-only pills also comes in the form of oral pills, implants, IUDs, and injectable medication. Long-acting reversible contraception using the copper IUDs and progestin-only subdermal long-acting implants. Barrier and natural methods like diaphragms, cervical caps, condoms, spermicidal jellies, and fertility awareness. Tubal ligation vasectomy procedures are the sterilization procedures, and in the emergency contraceptions, progestin-only pills and copper IUD should be advised. These examples are common but should not be considered as exhaustive list. Coming an important topic of the male and female sterilization. The failure rate for sterilization procedures are approximately 1 in 200 for women and 1 in 2,000 for men after vasectomy. After sterilization, the risk of hyperglycemia and diabetic ketoacidosis increase, especially in women with type 1 diabetes. However, with appropriate management, the potential complications are minimal, making this the best choice for women who do desire additional children. Coming to the postpartum contraception care, approximately 50% of women resume sexual activity by 6 weeks postpartum. Post-delivery contraceptive plans should be developed before delivery. Providers should have open discussion with the patients about barriers to appropriate diabetes care, the expense of diabetes supplies and the medication, the need for daily blood glucose monitoring, and the biological, psychological, and the social demands of the postpartum period. Socioeconomic factors are also important consideration when planning for post-delivery contraception. Women who can't afford to follow a given treatment plan and anticipate provider criticism may be more likely to delay or forego the parental care. Postpartum follow is very essential, which we have to educate regarding the possibility of the future diabetes, give information regarding lifestyle changes, add metformin if the pre-diabetes is present along with diet and lifestyle modification. Long-term follow-up is essential and emphasize on breastfeeding. What is the checklist for the pre-conception care of the women with diabetes? Evaluate the general overall health, counsel on diabetes and pregnancy, reviewing risk and benefits, discuss the glycemic goals before pregnancy, implement contraceptive plan with the patient to prevent pregnancy until the glycemic targets are achieved, which is the keeping the HbA1c to less than 6. Evaluate preconception diabetes and its comorbidities. Evaluate the obstetric and gynecological history. Implement management plan for the general health of the patient and the support system the patient is having. Review current medication and the appropriateness during pregnancy. Aim for a target blood pressure to be less than 130/85. Discuss all the lifestyle recommendation. Complete a comprehensive nutrition assessment. Discuss the nutrition supplements during the pregnancy and proper medication usage. Discuss the routine screenings and immunization before and during pregnancy. Involve the multidisciplinary team, for example, the primary care provider, obstetrician, gynecologist, endocrinologist, diabetologist, nutritionist, and diabetes care and education specialists in patient care. Particularly in this pandemic with the COVID on the rise, the COVID vaccination can even be given during pregnancy and even during the lactation period. And there has been clear-cut guidelines from the government of India about the COVID vaccination in the pregnant female, even after the delivery. Similarly, the influenza vaccine should be because of the increasing incidence of the pneumonia, and the pneumonia vaccine should be advised to all the pregnant females. Thank you very much. The basic aim of my talk was basically to tell the audience about what we call what should be done before planning a pregnancy, what should be the target for the blood sugar control before planning pregnancy, what should be the target of the blood pressure before planning pregnancy, what you should do to maintain the blood sugar level throughout the pregnancy under the what you call the ideal control, what should be done to maintain the blood pressure throughout the what is the limited available targets of 130/80, and what should you advise the patient when the patient delivers. The follow-up is so important in order to know whether the patient is still having diabetes or the patient has become normoglycemia, or during follow-up after 6 weeks, 6 months, or 1 year, we have to redo GTT to see whether the patient is able to maintain blood sugar or not. Contraception, I have discussed in detail what kind of a contraception we have to advise to the women, because today the family medicine, the planning of the conception, the planning of the pregnancy, the contraception, the control of diabetes, blood pressure, follow-up is so important so that we can prevent the development of the complication, development of the maternal fetal complication if we give proper advice to our patients. Thank you very much.
Thank you so much, sir, for the lucid presentation. Dr. Rinkal, go ahead.
Good evening. I'm delighted to invite our next speaker, Dr. Subhankar Chowdhury. He's professor and head in Department of Endocrinology in IPGMER and SSKM Hospital from Kolkata. The topic is changes in sugar hyperglycemia pattern during various phases of pregnancy.
Very good evening, and a warm welcome from Kolkata to SwasthyaCON, and sincere thanks to the entire team of SwasthyaCON, especially Dr. Mayur Patel, Dr. Yash Patel, and all of you. So after this wonderful talk by Dr. Subhash Wangnoo, which talked of very practical issues, my brief is essentially to maybe go through a little bit of physiology, pathophysiology, and understand how does glucose change during pregnancy, which could be both normal pregnancy and also those complicated by diabetes. So what I intend to do is first to talk about the changes quickly, then maybe to try and understand why or in what way these glycemic pattern changes could affect pregnancy outcomes, and then to know how best to understand this or how best to evaluate these glycemic pattern changes. So Dr. Wangnoo has already mentioned all the different risks to the mother and the fetus. I would only like to add that hyperglycemia in pregnancy affects not only the mother and the infant immediately after birth, but there could be long-term implications in terms of leading to higher risk of type 2 diabetes, both in the mother as well as in the child, high risk of obesity, metabolic syndrome in the child. And I found it interesting that in the child, maybe cognitive disorders could be higher in those born out of pregnancy complicated by hyperglycemia. So the changes in carbohydrate metabolism during pregnancy. We all talk of pregnancy as a diabetogenic state. I wish to point out that this refers essentially or more so to the second half of pregnancy, where you have increased insulin resistance. In the first half of pregnancy, in the first few weeks of pregnancy, actually, you may have a facilitated insulin action rather than insulin resistance. We need to keep this in mind. And we should also refer to these terms that we have heard several times and try and explain what they mean: accelerated starvation in fasting and facilitated anabolism in fed state, which are actually nature's way to help both the developing fetus, which needs nutrition all the while, as also to try and help the mother to keep up her overall nutritional state. So in the first weeks of gestation, where we have increased levels of estrogen and amount of beta cell, at least hypertrophy, if not hyperplasia, so that there is increase in insulin secretion in the early weeks of pregnancy. On top of that, there is increase in plasma volume, and also there is progressive increase in fetoplacental glucose utilization. So they take away glucose from the mother's blood. So what actually happens is that compared to non-pregnant fasting blood glucose, maternal glucose tends to decrease a little bit, maybe 5-10% in the first few weeks of gestation. So you do not typically in a normal pregnancy, or even in a pregnancy which later will be complicated by gestational diabetes, in the first few weeks, you do not see an increase in the fasting glucose. However, in the later part of gestation, it's a different picture. You have a lot of placental hormones being secreted, most important of which in relation to glucose metabolism is human placental lactogen, as also cortisol, as also growth hormone, all of which are counter-regulatory hormones, all of which cause increase in insulin resistance. So it says up to 50% increase in insulin resistance, which leads to a reduction in insulin-stimulated glucose uptake, and hence the possibility of development of gestational diabetes in at least a certain proportion of these women. And then about this accelerated starvation terminology that we have all been listening. Now, in starvation, in fasting, we know there is an attempt by the body to maintain nutrition or energy supplies through increased fat catabolism by lipolysis, which tends to give rise to ketogenesis. And these are driven by hormones like cortisol and growth hormone. Now, in pregnancy, and especially in the second half of pregnancy, when the fetus is rapidly growing in size, the placenta is also growing in size, they're continuously removing from the maternal circulation glucose as well as amino acids. And this gives rise to maternal substrate deficiency. And that in turn sort of activates what normally happens in prolonged fast or starvation, that happens much quicker. So the metabolic changes that occur only after 72 hours of fasting in non-pregnant state occur within 48 hours in pregnancy. Hence the term accelerated starvation in pregnancy. And this is clearly designed to provide nutrition to the fetus at the cost of the mother, so to say. But there's also something called facilitated anabolism, so that in the fed state, when the insulin level rises, it helps then to activate the anabolic processes. So whatever was lost during fasting is recuperated. Now, here we have two hormones. One is glucagon, the other is insulin. Now, while glucagon is more readily suppressed following glucose load in pregnancy. Now, insulin is stimulated by both glucose and by amino acids. Both would cause increase in insulin. On the other hand, for glucagon, glucose causes suppression of glucagon, but amino acids cause stimulation of glucagon secretion, just like as it does for insulin. So in the immediate post-mixed meal state, where a person would have consumed protein, fat, carbohydrate, everything, there is increased level of insulin because of both glucose and amino acids stimulating insulin secretion. And this decreases gluconeogenesis from amino acids. So amino acids are not so much utilized. So that at a later part of the post-mixed meal state, there is persistently elevated amino acids, and which we know in pregnancy also will continue to stimulate glucagon, and hence it will now give rise to gluconeogenesis in a later part of the post-meal state, so as to prevent a reactive hypoglycemia in the mother. So now nature also is trying to help the mother prevent the hypoglycemia in the mother occurring in a few hours after she has taken her meal. So these are sort of the most important part of my discussion, but I go on and try to explain what happens to glucose metabolism in normal pregnancy. So the stars are your insulin molecules, and these dots, black dots, are the glucose. And on the right-hand side, we talk of peripheral insulin sensitivity. Let's say someone has got a normal insulin sensitivity before pregnancy. In pregnancy, and here we refer to essentially the later half of the pregnancy, there is decrease in the insulin sensitivity. But that is compensated in a normal pregnancy by the beta cells of the pancreas by putting out more insulin, more stars in the circulation, so that the glucose level eventually is not allowed to increase. And after pregnancy, everything goes back to hunky-dory, everything is normal, your insulin sensitivity is normal, so the insulin secretion by the pancreas also comes down and the glucose levels remain the same. So that's normal pregnancy. What happens in gestational diabetes? Well, as we understand, the insulin sensitivity is decreased. We talked of insulin resistance, that is increased, which means the sensitivity is decreased. And now the beta cells of the pancreas cannot compensate enough, cannot produce enough amount of insulin. So you don't see so many increased number of stars there. They are about the same as in pre-pregnancy condition, and hence the glucose level rises. You have more black dots here. Post-pregnancy, in most individuals, the insulin resistance comes down, the beta cells are functioning about the same, and the glucose level comes down to normal. However, there will be a small number of individuals where either the beta cell dysfunction persists even after pregnancy, so that the hyperglycemia may persist in a small percentage, but typically the glucose levels come back to normal. And so if we trace the insulin requirement in a woman, specifically maybe a type 1 diabetes who has pure insulin deficiency beforehand, we find that in the first few weeks of pregnancy, there is actually slight decrease in the insulin requirement. And actually beyond the first, and as we go into the second trimester, the insulin requirement increases, goes on till the third trimester. And in the very later part of the third trimester, partly because the placental hormone secretion, the counter-regulatory hormone secretion tends to fall a little bit, maybe at the very later part, there is again a slight drop in the insulin requirement. So this is, I think, will help us understand how we may need to change the insulin doses during pregnancy. So quickly, I'll try and go through the glycemic pattern detection in normal pregnancy, gestational diabetes, or even pre-existing diabetes, and what are the clinical implications. So one of the important consequences of hyperglycemia in pregnancy is fetal macrosomia, big babies. But if you look at the prevalence, of course, it's much higher in those with gestational diabetes, but even in otherwise normal women, there is a certain percentage, though smaller, where you can have babies with macrosomia. And we also need to remember, if we look at all maybe 100 macrosomic infants, only a relatively small proportion will actually be born out of gestational diabetes. Many more would be born out of otherwise normal pregnancy, but partly it's related to obesity in the mother. And in women with gestational diabetes, whose self-monitored blood glucose values were within the normal range, were within targets that we have set, could still deliver macrosomic infants. So that makes us try and understand whether the glucose levels that we are able to detect by our standard measure, either lab tests or even self-monitored few tests, whether they're enough to tell us about the overall glucose dynamics during pregnancy. And especially the HAPO study actually did show us that there is, and this is a large study, you remember, from 25,000 pregnant women in 9 different countries, that there is a continuous relationship between any maternal glucose level and primary outcome, especially birth weight. So there isn't a clear cutoff. So it's a continuous relationship. So even within the so-called normal range, if the glucose level is a little bit high, the baby's birth weight is a little bit more. And similarly, if you do an ambulatory glucose profile or a continuous glucose monitoring in women, we find that the normal mean level of fasting glucose or 1 hour post-meal or 2 hour post-meal are quite low, 75 for fasting. For 1 hour post-meal is 105, 2 hours post-meal is only about 97. And on the left-hand side, we have put the recommended glycemic thresholds for either diagnosis for gestational diabetes or the treatment goals in those who have got diabetes, which are clearly much higher than what is normally seen in women in pregnancy. So this is looking at number of observational studies over a fairly long period of time to look at patterns of glycemia in normal pregnancy. And what it once again showed, and
hello, sir. Sorry to interrupt you, but you have left 2-3 minutes because we are exceeding the time.
Yeah. Yes. So once again, it suggests that the 1 hour glucose level, if you take mean plus 1 standard deviation, is only about 122 milligrams, whereas the 2 hour level is only 110 milligrams per deciliter. So clearly, possibly the targets need to be even more tight. And then we come to the importance of CGM, continuous glucose monitoring for in pregnancy. And that clearly shows us a whole lot of abnormal glucose dynamics, whether it's GDM or a normal pregnancy. Moreover, in those complicated by diabetes, continuous glucose monitoring shows up many more episodes of high postprandial glucose levels and nocturnal hypoglycemia that may otherwise go unrecognized by intermittent glucose monitoring. And hence, and it has also been shown, at least in type 1 diabetes, having going through pregnancy, that CGM or continuous glucose monitoring is associated with improved neonatal outcomes. And hence, we also need to understand that alteration of insulin requirements could also result from infections, use of steroids, use of tocolysis with beta mimetics, and all that. So finally, the take-home message is that there are changes in insulin secretion and insulin sensitivity in all pregnancies. Failure of adaptation is what leads to gestational diabetes. Glycemic patterns are altered in normal pregnancy, as well, of course, in pregnancy with hyperglycemia. And continuous glucose monitoring can alter treatment decisions in pregnancy with diabetes, and insulin dose requirement changes through gestation, as we have just seen. So with these few words, I would like to thank once again the organizers for providing me this opportunity, and we'll, of course, be happy to take any questions. Thank you very much. I'll stop sharing.
Thank you so much, sir, for the lucid presentation. We'll go for the third session for today's talk. Speaker is Dr. Minal Mohit, and the topic, current description and future need for multidisciplinary PCOS clinic. She is a consultant diabetes and endocrinologist, Manipur Hospital, Jaipur. Over to you, ma'am.
Hi, good evening, everyone. So first of all, I must thank the organizers of SwasthyaCON, Dr. Mayur, Patel, and the team for inviting me on this platform. Thank you very much. The topic is very relevant in today's scenario that we are going to discuss this evening, that is PCOS, polycystic ovarian syndrome. The relevance of the topic, especially when we physicians are dealing with it, is more important because PCOS is not something, a very myopic vision that is limited to only ovaries. PCOS, as the term goes, is a syndrome. And when we talk of syndrome, that definitely means that it's a cluster of many diseases. So the million-dollar question is, can anybody tell me what is the most common endocrinopathy in women of reproductive age? Yes, we all agree that though the misconception is that it should be type 2 diabetes or hypothyroidism, but actually no, the most common endocrinopathy of women of reproductive age is polycystic ovarian syndrome. So what is PCOS? Why is it important? What causes PCOS? Can PCOS be cured? And the most important question that every woman needs to answer, can I be a mother? So what is PCOS? As I told you, it's a cluster of syndrome. It's a cluster of symptoms. It is not just something related or limited to ovaries. It involves the entire existence of a woman. Beginning with the diagnostic criteria, the most important and well-known are the Rotterdam criteria. But before the Rotterdam criteria, way back in 1990, we had the NIH criteria, which involved menstrual irregularities due to oligo-ovulation or N-ovulation. Along with it, there was evidence of hyperandrogenism, but both the conditions were only taken into consideration when other causes for above two were ruled out. Then came the Rotterdam criteria, which were very popular and which is well known still, which added the sonography, that is the USG importance to PCOS, and which gave the criteria that oligo-ovulation and ovulation, hyperandrogenism, plus the USG evidence of polycystic ovaries. The number of follicles were also defined. They should be 12 or more, and each follicle should be about 2 to 9 millimeters in diameter. They also mentioned the size of the ovaries, and they also mentioned the size of the stroma. Then came the Androgen Access Society guidelines, or the Androgen Access Society criteria, which also added, besides these two, that there should also be exclusion of the other causes of hyperandrogenism. So practically, this gave us few phenotypes of PCOS. When we look at the phenotypes of PCOS, the most severe variety is the one with having menstrual irregularity, hyperandrogenism, as well as the USG criteria of PCOS, that is the number of follicles being more than 12. Then there is the mild variety, that is the PCOS with only menstrual irregularities and the sonographic evidence without hyperandrogenism. Then we have the ovulatory variety, which includes androgenism, ultrasound evidence of follicles, but no menstrual irregularity. And we also have the this is a non-ovulatory variety. Then we also have the ovulatory variety, which we have hyperandrogenism with menstrual irregularity, but no USG evidence of follicles or the USG evidence of polycystic ovaries. Coming to the clinical features of PCOS, the most important is the irregular cycles, that is the anovulatory variety. The periods or the cycles are consistently more than 30 to 35 days, and any woman, it is said, having less than 10 periods per year is probably having PCOS. We are ruling out the pregnancy here. Then coming to the pathophysiology or the axis, we know that in a normal woman, hypothalamus makes release of gonadotropin releasing hormones. which goes and acts on the pituitary to release the gonadotrophins, which act on the gonads and release estrogen and progesterone, which acts on the uterus. So this is a normal HPA axis. Normally, this is the ovulation. When at the time of LH surge, there is ovulation. Then at the time of estrogen surge, the menstrual bleeding happens. In PCOS, actually the defect begins right from the hypothalamus, that there is gonadotropin releasing hormone becomes abrupt and there is loss of pulsatile release. As a result, we get a uniform or a well-maintained levels of LH. There is LH surge, the LH level rises, and in the face of risen or a high LH levels, the ovaries fail to ovulate regularly. As a result, we have features of hyperandrogenism that leads to the male type hormone. We know androgens, the male type hormones. So there is increased beard and facial hair growth. There is also male pattern alopecia. There can be acne, and that all can be evidenced on the blood test. Then comes the sonography, which gives you a typical follicular pattern. You can see the follicles, they're all arranged in a string pattern. So what is not PCOS is very important to remember. Any sonography report with a single cyst, any woman coming to you with loss of periods because of stress or rapid weight loss or excessive exercise, or loss of periods because of premature menopause, that is premature ovarian failure, that is not PCOS. Weight and PCOS has a very significant issue, very significant correlation. All women who are overweight are more likely to have PCOS. I'm not saying that lean, thin PCOS are ruled out. No, we do have lean, thin PCOS also, but mostly PCOS are overweight women, and weight loss helps them in caring or at least controlling the symptoms of PCOS. Now coming to why PCOS is important, because as I told you, it is the most common endocrinopathy affecting almost 12 to 20% of the women of reproductive age. The short-term and long-term consequences also make PCOS important. Short-term, of course, are irregular cycles, hirsutism, acne, infertility, and psychological defects or the psychological disturbances that a woman undergoes. But long-term consequences are more important to we physicians, because these are the women who will later on come to us with type 2 diabetes, increased cardiovascular diseases, strokes, and heart attacks. So there's a huge list what we need to look for in a woman coming to us with PCOS. Infertility, DUB is one thing. More of it is endometrial carcinomas we are afraid of, obesity, OSA, type 2 diabetes, dyslipidemia, hypertension, possibility of cardiovascular diseases. Then a family history of PCOS, her children, her daughters especially, more likely to have PCOS are the things that we are looking for. So how it actually happens is, as I told you, it is the defect beginning right from hypothalamus, loss of pulsatile GnRH, leading to rise in LH. Rise in LH affects the thecal section of the ovary, so there is hyperandrogenism, and hyperandrogenism gives us the clinical features of acne, hirsutism, and also irregular cycles. Hyperandrogenism also leads to increased adipose tissue and insulin resistance, and overweight, obesity is also related here. Overweight, obesity, insulin resistance leading to further worsening of PCOS. So how do we diagnose PCOS? History and physical examination are quite often sufficient, but we need to prove it. We need to give the evidence to the patients. So we need to go for some ultrasound, we need to go for some lab assessments, and we have a list of tests that we do. Then also the insulin resistance, we of course look for the RBS at times, OGTT at times, dyslipidemia, and there are tests like increased LH levels, increased LH-FSH ratio, increased levels of DHEAS, increased levels of free testosterone, or decreased levels of sex hormone binding globulins. These are some of the other tests that we need to do at times to give evidence to our clinical diagnosis. Now the important question, can we cure PCOS? Definitely we do not cure PCOS, but we do effectively treat PCOS. And how do we treat PCOS? Number one to begin is always the lifestyle changes. Even for the thin PCOS or the lean thin PCOS, lifestyle changes remain the first line action, the first line treatment, because there is insulin resistance even in the thin women, or the thin women can also have intravisceral fat. So weight loss or a regular exercise and diet control is the first line management. And then come the remaining, and how do we do it? Weight loss is first, of course, as I told you. We can also go for bariatric surgery to control weight if it is really too much. Then coming to regulating the cycles. So if the woman is not looking for pregnancy, we can start on OCPs or the oral contraceptive pills. But if the woman is looking for pregnancy, then OCP is not the answer. In that case, we need to go for either ovarian drilling, or we can even go for gonadotrophins, that is FSH. For hirsutism and acne, we can go for cosmetic treatments. Cosmetic treatment includes the laser or waxing or epilation. Then we have certain drugs also that help us, that is anti-androgenic, and especially spironolactone is the most commonly used molecule. We are also using flutamide for the same reasons. Then coming to the women who are looking for pregnancy and fertility. So what do we offer to the women who are looking for fertility? What is the scheme of treatment? Now, unfortunately, we do not have any well laid down scheme to treat infertility, but we treat infertility always, we begin with induction of ovulation. So to induce ovulation, we either use insulin sensitizers. For example, metformin is most commonly used. Then we also use molecules like clomiphene citrate. We can use gonadotrophins, that is FSH. We can also use aromatase inhibitors like the letrozole. Even ovarian drilling can be used. Clomiphene citrate is the most commonly used molecule, and we begin with 50 milligrams and we go up to 150 milligrams. It is started from day 5 of the cycle. We give for the 6 days and then we stop clomiphene. We wait for the ovulation to happen. And if it does happen, it is good. If it does not happen, we try the same formula for at least 6 cycles. Combining clomiphene with metformin has always given us good results. Metformin is a very significant insulin sensitizer and targets insulin resistance. We can go up to 2.5 grams of metformin, and combining metformin with clomiphene citrate is giving us significant results. But always remember, to get pregnancy, we are not targeting insulin resistance, we are targeting hyperandrogenism. So we can go up to 6 cycles, but if the patient is facing clomiphene citrate resistance, we can even go up to more cycles, maybe even 12 cycles or maybe 48 cycles. Even people have tried up to 48 cycles. If the results are still not there, we can do a priming. A priming with dexamethasone has shown good results at times, or a priming with other molecules like the OCPs have also given good results. At times, letrozole, that is aromatase inhibitors, can be used to get ovulation. But always remember, letrozole is still not a molecule which has been approved for the similar results, for the similar indication. Letrozole, that is the brand name Femara by Novartis, it is still an experimental drug and it is approved only for breast cancers. So next line is gonadotropin therapy or ovarian diathermy. Gonadotropins, as I talked, FSH can be used beginning with some 25 to 50 international units per day. You can go up to increasing the dose by almost 100%. That is, you can go to 100 international units and you can have good results with follicle FSH, that is follicular stimulating hormone. But remember, ovulation does not alone does not guarantee a good pregnancy or a good outcome. Ovulation needs fertilization, then it needs implantation, then we need a fetal viability, and then we need a good healthy baby and a healthy mother. So IVF is always another option available to us. But always remember that a PCOS pregnancy is always a high risk pregnancy. There are chances of pregnancy diabetes, there are chances of gestational diabetes, there's chances of gestational hypertension. There are also chances of a low birth weight babies or a SGA babies. The newer molecules that are being tried to treat PCOS but are still not approved are melatonin, which improves ovarian functions and oocyte quality, then N-acetylcysteine, which again improves insulin sensitivity and decreases free testosterone. We have myoinositol, which is being used to reduce hirsutism, acne, and weight loss. Alpha-calcidol and chromium again improves insulin secretion and insulin sensitivity. Then we have L-methylfolate, which reduces homocysteine level and prevents the cardiovascular diseases. So these are the newer molecules which are in pipeline, frequently used, but with not found their place in the guidelines so far. So this is all about PCOS in brief that I can talk today evening. I am open to any questions. If there are any queries, I will be happy to take and happy to answer to the best of my knowledge. Thank you so much. Just to summarize before I leave the session, preconception, you must recommend cessation of smoking and alcohol. Weight loss is another important factor. Screen for glucose intolerance in diabetes. If the woman is overweight, weight loss is the important factor that is required for PCOS control. Though it is difficult to achieve and it does not guarantee a pregnancy or a good outcome, still weight loss is important. When you are targeting pregnancy, do not target caloric restriction at the same time. Couple screening is also important. Do not get biased by PCOS. At times, the fault or the defect may be in another partner and we are just running after the PCOS women. Then also always rule out a tubal blockage before going and treating any other thing. Confirm a tubal patency. Then the first line therapy is, of course, oral anti-estrogen, that is clomiphene, and perhaps letrozole can be tried. Adjuvant therapies like metformin, OCP priming or OCP pre-treatment, and even dexamethasone pre-treatment. Thank you so much. So PCOS women are also equally fancy and charming women. So with all due respects and regards, once again, I thank the organizer for inviting me here. Thank you so much. Looking forward to your queries.
Thank you so much, ma'am. It was a lucid presentation. Learned a lot today. And we are open for a question and answer session.
It is indeed pleasure to get all the faculties to talk on a specific, the women health, and specifically focus on metabolic diseases. And like you rightly mentioned, Dr. Subhash as well as Subhankarji, that where infertility to the hyperglycemia management, and when madam mentioned about also about how to take care PCOS. So these are some of the aspects we really miss out in the metabolic syndrome, that the PCOS is also one of the extension. And from there, even the dry vaginitis is also one of the part where stigmatus is around. So if you want to share, Subhash sir, about the same, that how that stigma is break around and what conversations we take around. All faculties, even the both chairs are so wonderful lady that they practice clinically in that extent on a great extent. So we like to get the all inputs from your side. Please, sir.
Subhankar, go ahead.
Yeah, I think it's a continuum that we are talking of, and we are looking at different aspects of one's life. So possibly PCOS first and maybe diabetes later. And then, of course, it could be diabetes in pregnancy as well. So PCOS is an issue which has different connotations to different groups of women. For some, it's the hirsutism. For some, it's the irregular periods. For some, it's the infertility. My personal take or my personal observation also has been that the menstrual irregularity part, because there's a question, very important question raised by the last speaker about whether PCOS can be cured. I feel that as one progresses from PCOS to type 2 diabetes, not everyone does so. We do understand that type 2 diabetes develops when the body can no longer compensate for the insulin resistance by increasing insulin secretion. So the insulin secretion gradually falls. Now, many of the features of PCOS are actually driven by hyperinsulinemia. So as the hyperinsulinemic state gradually dwindles over the years, many a woman with PCOS will actually have regularization of the periods, sort of in a way leading to a spontaneous, if not cure, spontaneous improvement of the periods. So that's my observation that I've seen. So of course, we can have other comments now.
I think Subhankar, you're right. You rightly said PCOS basically, which may have its origin right from the mother gets pregnant to the fetal origin. And because the main drive is the hyperinsulinemia or the insulin resistance. And you rightly said with the lifestyle modification, losing weight, bringing down the insulin level, we have seen many of the PCOS having normal cycles, and they even conceive spontaneously without any ovulation induction. This is pretty common. So our first treatment to all the PCOS, we always tell to undergo the lifestyle modification. If they are obese, try to reduce weight as much as possible they can. This is because my observation also. And second thing, what I have seen, because the topic basically was the multidisciplinary approach for the PCOS, because sometimes I have seen many of the young girls, they land up with the obstetrician and gynecologist, even when they have a significant hyperandrogenism, which is the domain of the endocrinologist. To treat the hyperandrogenism, they land up with the gynecologist, they just treat them with the OCs without realizing that OC alone is not going to be helpful. And because it keeps their cycle regular, but the hirsutism does not, it doesn't get affected. And suddenly I see most of the patients, they get to the endocrinologist for the treatment of the hyperandrogenism. And I have seen in my practice, basically the combination of the OCs containing cifloturon acetate with ethinyl estradiol and a good amount of spironolactone, maybe around 100 milligram at least per day, is very good effect on the hirsutism. But mind it, even after giving the OCs combination of the spironolactone, depending upon the severity of the hyperandrogenism hirsutism, what we grade, Pelham Garabi score, we had to give them the assisted the technique with the laser along with the continuation of the treatment. What I see, the patient going for the laser without correcting the underlying hormonal problem. And they come back to us after taking 6 sittings of laser, doc, my hair growth is the same. It is again appearing. So mind it, all the patients who are going for the laser treatment should be under at least 3 months of treatment with the combined OCs and the spironolactone before they go for the laser treatment. And it should be continued even during the laser treatment. That is my experience.
Thank you for the inputs. And I'll ask our chairpersons if is there any questions to go ahead, or we can close the sessions. Please.
So I have a query that pre-gestational diabetes patients, they are on OHAs, and when they plan to conceive, when is the right time to stop the OHAs and shift them to insulin? Because many have insulin resistance, and especially my patients are on pioglitazone. And we can, start with insulin, but Pio's effect stays for a very long time. So I want to know that what is the right time? Should we continue? And because sometimes the patient come when they conceive, they don't approach to us planning before the pregnancy. So what should be, when the patient comes on the right time, when should we stop, especially pioglitazone? How much time before they plan to conceive?
The pioglitazone starts only after 3 weeks. Because if you see the mode of mechanism of the action, what I tell the patient, at least 3 months prior to the planning of the pregnancy, if the patient is on any OHA other than metformin, I stop it. If the patient is controlled on metformin with the HbA1c of less than 6.1, which is the criteria for the planning a pregnancy, when that HbA1c is around 6.1. If she is having a HbA1c 6.1 with the medicine like metformin, no other drug, we continue the metformin, and during pregnancy, when the sugars start going up, we add insulin for a better glycemia. This is my plan.
Okay, sir. And what about pioglitazone, sir? Like
at least 3 months prior.
3 months prior. Okay. Thank you, sir. And metformin is safe during the pregnancy, pre-diabetic especially.
Yeah.
Okay, sir. Thank you, sir.
Pcos who are on metformin, we continue metformin even when they conceive.
Yes, sir. Yes, sir. PCOS we have to continue, but the main question with the pre-gestational. Yes, sir. Yes, sir. Thank you, sir.
Yes, Heena, madam. We can conclude the session. Yes, Dr.
Yes,
Rinkal and Dr. Heena. Please go ahead.
Yes, sir. So I would like to thank Dr. Subhash, Dr. Subhankar sir, and Dr. Minal ma'am for wonderful presentation. And we would like to conclude the session. Thank you, Dr. Rinkal, for co-chairing with me. Thank you so much. Thank you.
Thank you very much. We all enjoyed. Thank you.
Yes, sir. Yes, sir.
Stay safe.
It is indeed pleasure to share with all of you that this conference is monitored through Medical Council, and the conference is accredited by 11 credit points. So those who are willingly looking for this, make sure you log into website or in your email to get certificate after the end of the conference based on your time in the conference that would be certified. Thank you, everyone. Over to next session to my Master of Ceremony.